Hello, welcome to the EKG Guy. I hope you're having a wonderful week and I'm glad you could join us. So this week we have a 49-year-old male that presents with chest pain in this EKG. So what I want you to do now is try to go through the things here on the right, okay, the regularity, the rate, where's the rhythm actually originating from in the heart, the ventricular axis, if you can find that, atrioventricular and intraventricular conduction, okay, some of the waves and segments and intervals there, and then try to look at R wave and transitional zone in the precordial leads. So if you could do that, get a final interpretation, take your time, okay, and when you're ready, restart the video and we'll go through this together. All right, so again, we have our 49-year-old gentleman coming in with chest pain, this EKG. So the first thing we tend to do is find the regularity, okay? This is the approach I use, and it's so far, over the years, has held up well. So regularity. In other words, we want to make sure that the intervals between different complexes are the same throughout, okay? And so what do I mean by that? Well, oftentimes we look at the R to R interval. So if we look down here at V5, one of our rhythm strips down here, if you look at this R wave, okay, and this R wave, we call that the R to R interval. If you look at the one that follows, okay, and you can see that these are all R to R intervals because between different R waves, if you were to measure these out, they would be quite similar, okay, in duration. Remember, duration is in time is from on our x-axis going from left to right. So because these are pretty much the same between those intervals, we call this a regular rhythm. So hopefully you got that. Now we have the regularity. Next thing we want to look at is the rate, okay? And I find regularity because it helps me to decide, which way can I find the rate. Now oftentimes the EKG machine gives you the ventricular rate, not always the atrial rate, and therefore you always want to be able to find it yourself because again the machine is pretty good at finding the rate, but we don't always want to rely on it in all cases. So the rate, we'll look at the ventricular rate, okay, and therefore we'll look at these QRS complexes. Because we've been using V5, we'll go there. So one thing you should note is that from beginning all the way to the end of the EKG is 10 seconds, all right? And if you multiply 10 seconds times 6, that's 60 seconds, which is 1 minute in duration. Okay, so that means this 10-second strip, if you had 6 of them followed by one over another, you'd have 1 minute of beats. And what that means is if you count the complexes going across, multiply by 6, you can find the rate in beats per minute. So let's do that here. So here's a QRS complex, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So 14 QRS complexes, which represent ventricular depolarization, times 6 should give you a rate of 84 beats per minute. Okay, so we got 84 beats per minute. All right, so that's one way we can do it. Another way is that we know that these are regular between these intervals. So what we can then do is find a QRS complex that falls on one of the thick lines, okay? And we can use, say, this one here. It almost looks like exactly falling on that. And find the next R wave, which is this one here. And you want to count the number of thick lines between them. So 1, 2, 3, and it's between 3 and 4. And from there, what you would do is 300 divided by that number. So in this case, we said it's between 3 and 4. So if you say 3 is 100 and 300 over 4, okay, that would be 75. So the rate falls somewhere between there. Okay, notice that it's closer to the 4, so closer to this number as we saw with when we got the 84 beats per minute. Now the actual rate from the machine was 81. Okay, so as you can see, these are very close estimates. So those are how you find it. And the second way we just showed is how we can find it when we have a regular rhythm. That first way you can use for both regular and irregular rhythms. Next, we want to find the rhythm origin. So meaning, where in the heart is this rhythm originating from? Okay, and so what I want to do first is I tend to look at, are there complexes in which there's one P wave for every QRS that follows a T wave? Okay, and we tend to see that. And you also notice that these QRS complexes, okay, so if you imagine this is a P wave, QRS, P wave, QRS, and T wave, okay? These QRS complexes here are narrow, okay, in these cases, and they're normal. Because I know that, and that there's a P wave preceding each one, I know that it's not only coming from the ventricles, so in other words, this is what I'm asking myself, is where in the heart is the rhythm coming from? The atria, the right atrium, right ventricle or left ventricle, okay? And then we have our conduction system that comes through here, our SA node, internodal pathways, AV node, Bachman bundle, his bundle, right bundle, and then the left bundle has two anterior and posterior fascicles. So because I see it's narrow, I know that it's coming from above the ventricles, okay? So I know it's coming from above there. Because I see P waves preceding each complex at a normal interval, okay, normal PR interval, I know that it's coming from above our AV node and somewhere in our atria. So the next question, because it's coming from somewhere in our atria, okay, I have to ask myself, is this sinus rhythm? Okay, so is sinus rhythm present? So how do we determine that? Okay, well, sinus rhythm is simply stating that the rhythm is originating from the sinus node. So let's look here at that. So we have our heart, we'll draw again, okay. Again, our sinus node sits up here in our right atrium and conducts down to our AV node as well as to the left side to the Bachman bundle, all right, and like this. So if the rhythm is originating from here, we say that sinus rhythm is present. So imagine that we now take this right atrium and we overlay it on here, okay? Meaning that our sinus node is up here, and notice that the direction of the current is heading towards the AV node. In other words, in this direction. If you imagine now that this is 0 degrees, okay, this is like a quadrant system. This is positive 90, this is pretty much plus or minus 180 and negative 90 degrees. Notice that the normal P wave axis should be lying between the 0 degrees and actually positive 75 degrees. So this is normal P wave axis, okay? So remember that there's a normal QRS axis, ST segment axis, T wave axis. In this case, we're looking at the P wave axis. So what we now have to know is that because that wave front is moving in that direction, whatever it's moving to, it's a depolarization wave. If it moves those leads in that position, we should see upright positive P waves. So we have to know what leads are there. Well, we know that lead 1 sits here, lead AVF is down here, lead 2 sits here, okay? And then lead 3 is over here, and then we know that in our horizontal plane we have V4, V5, and V6, and such forth, okay? And we have AVR that sits here, okay? AVL is up here. So notice that it is moving in this direction towards these leads. Because it's moving towards those leads, we should see positive P waves in those leads, and because it's moving away from AVR, we should see negative P waves in AVR. So if you look at AVR here, notice that we see these negative P waves, okay? If we look at lead 1, you see these upright P waves. If you look at lead 2, same thing. Okay, AVF, you can see them down here, and then if you look over here on the precordial leads, you can see these upright P waves. Okay, so because you have that, you have P waves that have a same morphology throughout. Okay, they have the normal P wave morphology, and they're upright and negative in those leads we discussed. Sinus rhythm is in fact present, so this is a sinus rhythm. Okay, so hopefully that makes sense. So we have sinus rhythm, we have a rate of about 81 beats per minute, okay, and this is a regular. So regular rhythm, 81 beats per minute, okay. So far we have normal sinus rhythm present. The next thing we have to look at is the ventricular axis. So again, we looked at the P wave axis, now there's a ventricular axis. And the normal ventricular axis is between negative 30 degrees and about positive 110 degrees, okay? So in this region, we call that a normal ventricular axis. So notice it's much bigger than that of the P wave axis because you have more left ventricle muscle that's kind of making that up. Okay, and then up in this area, we call this a left axis deviation over here. this would be a right axis deviation. And in this region, we call this a right superior axis or northwest axis. So northwest axis. Why northwest? Well, this is north and this is west, so this is northwest. Okay, so hopefully that makes sense. So let's now add our leads. Lead 1 here sits at 0 degrees, and this is AVF at positive 90 degrees. Okay, and we use these, as we'll see, because they're the easiest to kind of, when you're starting to learn, to look for access. Okay, so if you look at lead 1, notice that our QRS complexes are mostly positive, meaning above baseline. So that means we're going to go towards the positive end of lead 1. Okay, so towards it. This would be the negative. And then if we look at AVF, okay, notice that these are also mostly positive complexes. So we'll go towards the positive end of AVF, okay, away from the negative. That means the axis lies somewhere between here, okay, which means that the axis is normal. In fact, the actual axis that was measured was 23 degrees, which puts you about in this area here. So this is a normal ventricular axis, and it was at positive 23 degrees, okay. So a pretty straightforward axis, but that can be quite tricky, and that's why we have multiple times that we practice this with every EKG, okay? They're not always as straightforward as that. Anyways, let's move on. Next, we look at atrial conduction. Okay, is the P wave prolonged? And in this case, it's not, okay? Less than 110 milliseconds. So our P wave here, we're looking at, is it prolonged here, okay? Is there any notching, or is it tall? Okay, in these cases, we tend to look at lead 2 and V1. They're the best to look for atrial abnormalities, and that I don't see any. So there's normal atrial conduction here, okay? Next, we look at atrial ventricular conduction. So notice we looked at the P wave here. Now we're looking at AV nodal conduction. Okay, so if I draw out, that's our complex there, and here's our heart. We saw we're in sinus rhythm, okay? So we did that. Now we're making ourselves down to this AV node here. So in this case, we're looking at the PR interval, okay? And if there's a P wave for every QRS complex. So we said that there's a P wave, QRS complex, P wave, QRS complex for each one, and all the P waves look the same. So there's a 1-to-1 ratio, okay? So 1 P wave for 1 QRS complex, which is normal, and that the duration from P wave, beginning of P wave, to the beginning of QRS complex is called the PR interval, okay? Now the PR interval normally should be between 120 and 200 milliseconds in adults, and we have a 59-year-old male, so this is an adult. And in this case, the PR interval, if you look here, is going just beyond that thick line there, okay? And you should know that from one thick line to the next is 200 milliseconds. So if you go beyond that, then you're starting to worry about a delay, okay? We call those AV nodal conduction delays or atrioventricular conduction delays, okay? This is the AV node. So there is actually a delay here. So the PR interval in this case was actually 204 milliseconds. So barely over, but it was over, so we'll note that. Okay. All right, next we're looking at intraventricular conduction. So again, we made our way through the AV node, and now we're looking down here into the ventricles. Now, intraventricular conduction is, first we want to look, is the conduction within the ventricle prolonged? Meaning from beginning to the end of ventricular depolarization, normally it should be between 70 and 110 milliseconds, at least less than 120 milliseconds. In this case, we certainly have that, okay? Now the QRS duration that was measured by the machine was 98 milliseconds, so we'll call that normal, and it was 98 milliseconds. So circle that abnormality there, okay? Next, I want to discuss some other things down here, and that includes the PR segment, Q wave, ST segment, and the QTC interval, okay? So let's start here with the PR segment. Do you notice anything about the PR segments? Okay, well, in this case, there's something that you should note. You should note that the PR segment is actually slightly depressed, okay? So notice that the PR segment is depressed in that, and seems somewhat elevated in AVR. So there's actually PR depression okay, in some leads, and as well as PR elevation that we saw in here in AVR, okay? And there's almost diffuse PR depression in some leads. So notice it here as well, here, okay? So in most leads, we'll say that, not in all. So that's one thing to note. The other thing is, are there any abnormal Q waves? Okay, well, I don't really see any abnormal Q waves, and we look for this because we want to ensure that there's no prior infarct. So when the muscle is damaged or infarcted and dies, then it's no longer electrically active, okay? And because of that, what you can have is Q waves that develop because it's pretty much silent, okay? So in that case, we don't see that here, so we will say that there are no Q waves or abnormal Q waves present. Next, we want to look at the ST segments, and this is where you probably noticed a lot of findings, okay? So let me erase some of these depressions and elevations of the PR segment, and now we're looking at the ST segment. So again, we're looking at this region here. Is there any elevation or depression? And notice that this here, there's some elevation in these leads, okay? Maybe slightly here, okay? You also see it in the precordial leads, which is quite prominent. And then you see some ST segment depression in this lead as well. So you see ST segment elevation, okay? And notice that it's upward, okay? It's pretty much concave up, okay, because of that. And we notice that it's quite diffuse. So kind of diffuse ST elevation that is kind of concave in nature. And we won't get into different patterns of ST segment depression, whether, how it makes a difference, but in this thing is something you should note. And there was also some ST depression in AVR. Okay. Next, let's look at the QTC interval. Okay, the QT is the interval between the start of the QRS complex to the end here. So this is what we call the QT interval. The QTC means corrected QT interval, which then takes into account the heart rate. Okay, and the QTC interval measured by the machine was 432 milliseconds and seems accurate, so we will not discuss further about that. Okay, the next thing I want to discuss are the last two things here, which are in the precordial leads. Okay, and this has to do with R wave progression and transitional zone. So again, we're focusing on these leads here, which are called the precordial or chest leads. And we want to see that the R wave increases when going from V1 all the way up to V5. Okay, and it's this initial R wave here. Okay, so it should initially go up in amplitude up until V5. And the other thing you can note is that not only it increases in amplitude, okay, so increase in R wave amplitude from V1 to V5. Another thing you could look for in normal R wave progression is when the R to S ratio increases. Okay, what do I mean? Well, there's an increase in R and the S wave goes down. So that's another way you can look for it. And again, in those same leads. So an increase in the R to S ratio. As the R wave goes up, you notice these S waves get smaller. So in general, there's some compounding things that we saw here with the ST segment, but this I would say is normal R wave progression. Now, transitional zone is where we go from mostly negative complexes in the right precordial leads to positive complexes here in the left precordial leads. And we notice that this seems to be mostly negative, okay? Here in V2, it still seems mostly negative, but in V3, we see that these are mostly positive, okay? So the transitional zone, in this case, is between V2 and V3, and normal transitional zone is often between V3 and V4, but given these complicating factors, it may affect it here, okay? And because it's coming earlier, we call that an early transition, okay, or a counterclockwise rotation. Anyways, that is not the main finding, but hopefully that's important. I want you to note those on the last few things we discussed with the transitional zone and R-wave progression. Those really depend on the lead placement. So again, that's an imperfect science, and it's the humans, we can make errors. So be cautious of how much weight you put in to those. All right. So let's now look and review what we have. So we have a regular rhythm at a rate of 84 beats per minute in sinus rhythm. So we would say that is normal sinus rhythm. We have normal ventricular axis and atrial conduction. We have prolonged AV conduction, we noted. So we would say this is normal sinus rhythm with first degree AV block, okay? Because you have a prolonged PR interval that's constant. So all of that prolongation in the PR interval is constant, and you have no dropped beats. That's why it's first degree AV block. Normal intraventricular conduction, and then we notice these findings here, okay? So these findings are of acute pericarditis. So this patient, I said, presented with chest pain, and just to note, compared to his previous one, he had normal sinus rhythm. So these are all new findings. So acute pericarditis, a few things I want you to know. He came in with chest pain, okay, and it was retrosternal pleuritic, so meaning when he was breathing, and it was worse when he was lying flat, and he had relieved when he leaned forward. He was somewhat short of breath, that I didn't mention here, okay, but he has a normal rate. Sometimes you can see them to be tachycardic, meaning they have a fast rate because of the pain. So he wasn't experiencing that. They may also have a friction rub that you hear on auscultation and even in effusion. So we see these diffuse ST segment changes that we saw with the concave up ST segments and depression. So the main ECG features you see in acute pericarditis are diffuse concave up, ST segment elevation, and PR depression of that segment, okay, throughout most of the limb leads, as we saw here, as well as the precordial leads, V2 to V6, you tend to see it. We see reciprocal ST segment depression and PR elevation, as we saw in AVR and V1, okay, plus or minus V1, not so much here actually, so mostly AVR, but you can see that. And patients may have sinus tachycardia. In this case, he had normal sinus rhythm. Now, there are a number of stages that these patients go through, okay, and it is often after about 4 weeks that you see normalization of all the EKG changes. Now, there are a number of causes from infectious, immunologic, such as rheumatic fever and lupus, and then you can have uremic patients. You can have some drugs such as cyclosporin or isoniazid that can cause this, but the most common is viral, okay, such as like Coxsackie virus is the most common causes of pericarditis. Okay, so another thing that I want to mention and that will help you notice that this is acute pericarditis is by looking here at lead V6. So lead V6, and what I want you to do is look at this PR segment and then look at that. Okay, you see that measurement. So what I'm doing is, if you imagine, here's our PR segment. We have something that looks like that. I'm taking the PR segment over, and then I'm measuring to the ST segment, so to this portion. Okay, so what you want to do is measure that and then compare that to this amplitude. So you're going to do that green area over this purple area. And if that area, okay, is greater than 0.25, so that ratio there, okay, which you can see here, that ratio seems to be about almost 50%, so certainly over this, that is highly suggestive of pericarditis. Okay, so that favors it, and I want you to just be aware of that in these cases. All right, and then another thing, if you want to compare it to benign early repolarization, you often see a fishhook pattern in V4 with benign early repolarization, but we don't really see that in this case very well, although it almost looks like there is. But so hopefully that makes sense there. So again, a great case of a 49-year-old male presenting with chest pain and was found to have be in normal sinus rhythm with this first degree AV block and have acute pericarditis. So very interesting case here. All right, well, that's it for this week. I hope you had you learned something here, and I hope you have a wonderful week ahead of you. All right, so I just want to mention a few things here before we end. This is our new reference guide that's now available. One of my partners, Dr. Noseworthy, who's head of the EKG lab here at Mayo Clinic, helped to edit this, and I'm grateful for all his help and mentorship. But what you could do is go to our site. My site here is this www.ekg.md. So www.ekg.md, and you can find that there. This is brand new, available. Shipping within the US is actually free at this moment. Okay, we have somewhat of a holiday sale, and so you can check that out there. Okay, I think it's actually only $3.99, so we're giving it at a great price here. So enjoy that. Now, the other thing I want to mention is our reference guide here that we have available, and you can get free access to that if you go to this link here. So just put that into your search bar, and then all you have to do is enter your email and click submit. You'll get an email to confirm that that is in fact you that wants access, and once you do that, you click on that link and you'll have access. And the coding reference guide here is amazing. Actually, you have all the different rhythms with examples available. You can look at conduction delays, voltage access, interventricular conduction, different ischemia patterns, okay, clinical disorders like Brugada. So many great things there. Okay, a lot of people are really enjoying this, and I just wanted to make that available for you as well. Okay, so a few new things. Obviously, we have our course and our books available at the site that you could check them out. Really grateful for all your support. If you have any comments or ways we can improve, I always love feedback, so just leave it below. Thanks so much for your support. I really appreciate it.